actually. She's going to talk on which tonometer to use for which patient. Go ahead, Doctor.
Well, thanks, Dr. Nangya and the chairpersons. I'm going to talk about which tonometer to use for which patient. It's a age-old topic, but let's just revise. These are the common methods that we use for intraocular pressure measurements, and all of us are very familiar with these in the clinics. The principles of measurement are largely flattening, indentation, or deformation of the cornea. So largely we are dependent on the cornea for measurement of intraocular pressure. These are the various tonometers that we will just touch upon. Well, IOP is a variable parameter, and most importantly, also we need to understand that it's not only the measurement, the IOP itself gets affected due to various factors like diurnal variation, exercise, systemic disease, our heart rate, etc. And further, to complicate the matters, there are factors which affect the measurement of the intraocular pressure. Since it is dependent on the cornea, so any change in the corneal thickness, biomechanics, refractive error, everything affects the measurement of intraocular pressure, including the scleral rigidity as well to some extent. So what do we need for a good tonometer? Well, we definitely need the accuracy of measurement, which is the most important factor. We want minimum variations in the measurement due to shape, thickness, and elasticity of the cornea. We want the least inter-individual variability, least affected by ocular and systemic conditions, and of course, we want minimal effect due to anti-glaucoma medications as well. So however, we are yet to find an ideal tonometer. And sorry, am I not audible? Okay. Okay. So, though we are yet to find the ideal tonometers, the gold standard for now is definitely a Goldman applanation tonometer, and we know that very well. Why? Because it is the most accurate so far, and the cost effective as well. It follows the Imbert fixed principle required to flatten a constant area of 3.06 millimeter on the cornea. The only prerequisite for that is an intact corneal surface, and patient should be able to sit upright on the slit lamp. There are methods to adjust for the astigmatic patient so that we can use the prism bars and convert the astigmatism to minus and measure so as to get the accuracy. However, there are certain factors that still affect applanation tonometry, that is the corneal variables, as I mentioned, including the refractive error. So these are the conditions where we actually cannot rely on GAT, and we have to do certain modifications or use other tonometers. Perkins is the next best, and close to applanation, best to use for children and patients who cannot sit upright or anesthetized patients. It is considered second best to Goldman applanation, and the IOP measurements are closely compatible to GAT. Tonopen works on Mackey mark principle, useful in corneal edema, scarring, irregularities, and even in infection, because we use a disposable sleeve which can be used. So all such kind of eyes we definitely used to need Tonopen. Rebound tonometer that works on a small plastic coated metal probe which is bouncing against the cornea and sends the induction current from which we deduce the IOP. And this is most useful in pediatric OPD because in children where we don't want to put topical anesthesia or they are not able to cooperate, this is a good tool to check in the OPD. It does overestimate the intraocular pressure as compared to GAT. Pascal DCT is something which can be considered ideal, but it is similar to GAT, but it is not depending on applanation. It is contour matching. It has a piezoelectric sensor which calculates the changes in resistance and gives us the intraocular pressure. It's supposed to be lesser dependent on CCT and corneal curvatures, but is not very commonly used because the probes are quite expensive. Also, the intraocular pressures are higher than GAT with particularly thinner and flatter corneas, so it takes care of those abnormalities. Schwartz is an age-old tonometer, no longer used though, but very extreme situations where we don't have any accessibility, measurement by Schwartz is also better than not measuring the intraocular pressure at all. Why it got unpopular was because of dependence on the ocular rigidity and high variability. There are certain tonometers which can take care of the biomechanical properties, and ORA is supposed to be the first one which could overcome the corneal biomechanics and gives us the accurate intraocular pressure. It gives us not only the intraocular pressure but also corneal hysteresis and resistance factor. So the IOPCC can account for the errors due to corneal biomechanics and may fare better in these situations where there is poor corneal biomechanics. And also parameters like hysteresis gives us the idea. The lower the hysteresis, the larger are the chances of glaucoma progression. The second best, or I would say technically the best for overcoming biomechanical properties is Corvus ST. It's a high resolution shine flood camera which calculates the reformation amplitude by putting a constant force of air on the cornea. And BIOP is supposed to be the corrected one, which is useful. And also the other parameters like deformation amplitude do suggest intraocular pressure in situations like keratoconus post-cross-linking. The newer indices of biomechanics are also useful, like biomechanical glaucoma factor, which is supposed to be more useful for patients with NTG, as it is an early indicator of NTG patients, or where we have the normal intraocular pressures as such. There are certain tonometers which are like transpalpable against the tarsal plate, very limited use, maybe in keratoconus patients. Phosphine tonometer, self-tonometry, but its sensitivity to detect is very low, so not very popular. Triggerfish was a contact lens embedded with a strain gauges to measure the elasticity in the limbus due to change in the intraocular pressure. But it tells you about the relative changes of intraocular pressure and not the absolute intraocular pressure, considered to be good for 24 hours, but not so popular still. There are certain implantable monitoring systems like IOL probes, or certain ADGOS studies tells you about the telemetric sensor which can be implanted during the cataract surgery and monitors the pressures throughout the day, but limited use because of the possibility of pupil distortion and uveitis. So basically, to select the tonometer for which patient, I would say for community screening, the Perkins, iCare and Tonopen fare better. All patients with intact corneal surface and are able to sit on the slit lamp, Goldman applanation tonometry for sure. For scarred and irregular corneas, you can use Tonopen. For patients under anesthesia or patients who cannot sit, or children, you can use Perkins. In regular clinic, children and patients who are not able to cooperate or are allergic to topical anesthesia, iCare or Rebound works best. And patients with poor biomechanics or corneal ectatic disorders or post-cross-linking or keratoconus, Corvus ST and ORA works better. However, we still have eyes like this where no tonometer can work better. Maybe there we have to depend on our digital IOP and other clinical parameters to estimate what is how much pressure we need to reduce. So with the knowledge so far, So with the existing knowledge, using appropriate tonometer for each situation for accurate IOP reading would help in managing glaucoma situations. Thank you for the patient listening.
Thank you, Sushma, for covering the topic.